you for the nice introduction and thank you for inviting me here. So at the outset, I would like to congratulate the faculty for hosting and organizing such a grand conference with such a good uh, audience and good comments so far. So today we'll be dealing with the diabetic kidney disease, which is one of the major complications of diabetes, as was highlighted by the chairperson. So we call it the CKD, chronic kidney disease, is a global killer in plain sight. People are not aware of chronic kidney disease. If you see the figures, roughly 18% of Indians have diabetes, 18 to 20%. Hypertension is seen in 25%. But do you know CKD occurs in 17%? CKD is almost as common as diabetes, but people are not aware of it. People are aware of diabetes, thankfully now, hypertension, heart disease, but they are not aware of chronic kidney disease. This is our own Indian study, which shows that out of all causes of CKD, diabetic CKD is the most common, the forerunner in India, which causes CKD. And unfortunately, though we have so many services available in India, India cannot provide dialysis to all patients of diabetic CKD. You must be aware of PM Yojana, where they are starting dialysis centers in all the districts of India. Huge exercise. But remember, even with all these facilities, we can do dialysis only for 50,000 new patients every year. And how many patients of CKD need dialysis every year? 2 lakh. So out of 2 lakh people, we will be providing dialysis only to 50,000 and 1.5 lakh will just die. We know that we have dialysis and transplant. So apart from the limited facilities, it's very costly. The dialysis is roughly 30,000 rupees per month. So 2,000 rupees per session, every alternate day patient comes for dialysis. So it's a very poor quality of life for the patient and it's lifelong. Transplant is available, but India does around 12,000 transplants per year. And we need how many transplants? 2 lakh per year. Can we meet the numbers? And then transplant is expensive as well. So if we don't treat diabetic CKD, this is where we end, dialysis or transplant, which is limited and the cost is huge. In addition, the diabetic CKD, apart from contributing to the cost and poor quality of life, look at the effect on cardiovascular diseases. A person who has diabetes and CKD is shown in the violet bar, and all risks are multiplied. Congestive heart failure, acute myocardial infarction, CVAs, peripheral vascular disease, ASCVD and death. Everything is multiplied so many times, twice, if a patient has both diabetes as well as CKD. Therefore, DKD management and knowing about it is important, and that's why the importance of this session. Now, remember, diabetic patient can have 2 types of kidney diseases. First, kidney disease, where the kidney disease is because of hyperglycemia. That is the main culprit. And this is typically diabetic kidney disease or diabetic nephropathy, as it was called. And here, generally, you have proteinuria. It progresses gradually, and it's associated with diabetic retinopathy. So this is the main focus of discussion today. And almost 70% of diabetics with kidney disease have this type of kidney disease. We call it DKD. Now, a diabetic person can have kidney disease because of other reasons. Maybe because of lupus nephritis, maybe some glomerular disease can occur in a diabetic. So these diseases are called non-diabetic kidney diseases. They are not associated with retinopathy. They have a rapid progression and they need separate treatment. So this is not we are discussing today. We are discussing diabetic kidney disease, which is because of hyperglycemia. Now, how do we identify diabetic kidney disease? What are the symptoms of kidney disease? Remember, we have 5 stages of CKD. In a diabetic also, we can have these 5 stages of CKD progression. The last stage is where the patient needs dialysis or transplant. And then slowly the patients of diabetes progress from 1, 2, 3, 4, 5 stages. In stage 1 and 2, there is no abnormality. Patient is completely asymptomatic. All diabetics, they may have CKD, many of them, but we don't know, no symptoms. So early DKD can be asymptomatic. The last stage, you have symptoms. And this is where the patient comes to the nephrologist. There's decreased urine output, swelling of it. So this everybody recognizes, and most of the patients in our OPs come in this stage when they have full-blown edema and swelling. The middle stage, the stage 3 and 4, again, they have symptoms, but many of the times the symptoms may not be related to the kidney. They may be affecting the blood, anemia, hypertension. The patient may have pruritus, may have loss of appetite, vomiting, and the patient may have cardiac symptoms, may have respiratory system, breathlessness symptoms. So the patients keep on going to different specialties. They never end up with the nephrologist. because creatinine is often not done, because nobody thinks that the cause of this symptom in a diabetic may be kidney, because the symptoms are related to other organs. So what I have emphasized is that diabetic kidney disease in the early stages, you may miss it. Therefore, screening is essential. So all diabetics, let us see what type of screening should we do. So what is the toolkit for screening? Only two tests, urine albumin and creatinine. With the creatinine, calculate the eGFR. So this message, all diabetics should undergo these two tests. This is the message which should go across. Urine albumin, repeated measurements are important, at least 2 out of 3 measurements. And we should not test for urine albumin in the presence of fever, UTI, or if the patient is pregnant or sugars are uncontrolled, CHF. So you should check when the diabetic person is otherwise stable. And we all know that microalbuminuria, then you have moderately increased albuminuria, severely increased albuminuria. So nowadays we don't use the term microalbuminuria, but again, we call it moderate or severe. Remember the numbers. Less than 30 milligram per day is fine. More than 300 milligram per day, it's already in the stage of severe albuminuria. So please do a urine albumin test. You can do it with a dipstick, which gives a semi-quantitative estimation, or you can send it to the lab and you will have this report. The other important thing is the creatinine and GFR. So asymptomatic diabetics also, this should be done, and get the creatinine from the lab. The lab can do the GFR if you want. Otherwise, this smart formula can be downloaded on all smartphones. It is free for download. And you use the CKD epi formula nowadays, not the other ones. So you have to just fill the creatinine, the age, gender. And the new CKD epi formula, even race is not. So creatinine, age, and gender, and you have the GFR. So on your prescriptions, on the physician's prescription, always urine albumin report should be there and the GFR should be mentioned. It's mandatory, which many of us do not do. So after checking the albumin and GFR, we can classify the patient as which stage of CKD. The left side, you can see the GFR, G1 to G5. So G5 means the last stage. So if the GFR is between less than 15, you call it G5. And suppose the albumin is more than 300, you call it A3. So if a person comes with albumin more than 300 and a GFR less than 15, you call it G5A3. So this is how it should look on your prescription. Just remember, think honestly, are you writing it? Many of us are not. We should do it. Even the nephrologists sometimes don't write. That is wrong. So that's the first step. You should screen and diagnose DKD early. So should you screen everyone? No. All type 2 diabetics from onset, you have to screen. Whereas type 1 diabetic, you can start screening after 5 years of onset of diabetes. So please remember, most of the patients are type 2 diabetes, and all of them annually urine albumin creatinine ratio and a GFR. Who should be doing the screening? Should the nephrologist do the screening? No, because by the time patient comes to nephrologist, they already have stage 5. So it's no use. Nephrologist should do it, but the main people doing it should be the physicians and GPs. You have 10 lakh physicians and GPs in India and only 2,000 nephrologists. So screening of all diabetics cannot be done by nephrologists alone. And they are the correct people, the physicians, because who will be seeing diabetic patients who are asymptomatic regarding the kidney. So all these patients, please screen. And if screening is positive, then we do all the other investigations, LFT, RFT, the iron profile, calcium profile. We also look at the ultrasound, lipid profile. So all these tests are done in case the screen is positive. And this is generally the domain of the nephrologist. Remember one thing, renal biopsy. So should we do renal biopsy for all patients of diabetic nephropathy? No, it's not required. You should do renal biopsy only when there are some suspicious features. For example, hematuria, rapidly progressive renal failure, nephrotic syndrome, systemic features, example, rash, or if the diabetic person does not have retinopathy. So these are the clues that the patient may be having the non-diabetic kidney disease, which I said maybe because of other conditions, not because of hyperglycemia. So this is not to be managed by the physician, refer to the nephrologist. So if any of these things are there, routine diabetic nephropathy, these things will not be there. No hematuria, retinopathy is generally there. It is slowly progressive. So those diseases should be managed by the physician, but any such suspicion, refer to nephro for a renal biopsy. Fine, so we have such patient who has come to your clinic, 47 years old, software professional. He's a diabetic hypertensive, he's a smoker. He is on the obese side, blood pressure 140/90, HbA1c is 8.3, creatinine is 2.1, his GFR is already 36. Cholesterol is a bit high, he has bilateral NPDR, and kidney size is normal. He is on metformin and glimepiride, telmisartan, CT. So this is generally the prescription what we get from many of the referring physicians or GPs. So is this enough? So there are 1, 2, 3 drugs on the prescription. Is this enough? What do the guidelines say? Remember, the first point in your prescription should be a diet advice. Healthy plate. So healthy plate for diabetic nephropathy is again like a normal plate. Half of it fruits and vegetables. 1/4 is carbohydrate, that too whole grain, and 1/4 should be lean protein. So this can be advised for all early stages of diabetic nephropathy. Avoid animal protein, go for plant protein. Plant protein is better. So protein should not be restricted in a vegetarian. They should be allowed to take all vegetarian protein diet. If they want to take animal protein, then you can use egg or chicken, fish. Meat should be avoided. And the first point on the prescription should be about diet, which should include salt advice. So say salt 1/2 teaspoon per day if the patient is hypertensive, 1 teaspoon if not hypertensive. But remember to tell, avoid salt substitutes. They will go and purchase salt substitutes. They should not be used. Go for natural spices. You can go for lemon. You can go for garlic and onion powders. They also have the same taste without sodium. Avoid soya salt. These things should be told, soya sauce and all. People have a lot of salads nowadays, then they put salad dressing on that. Salad dressing should also be avoided. It contains sodium. So this is the first point on your prescription. What should be the second point? Lifestyle advice. So for diabetic nephropathy patients, 150 minutes per week. That's 30 minutes per day, 5 days a week. Right? Stop smoking. That should be mentioned on the prescription. It's important. About BP control, what target? This patient is 140/90 BP. Is that okay? No. What do the latest guidelines say? Bring the BP down to 120 unless the patient is not able to tolerate it. Fine. So the second should be about BP advice, target BP, and what drug. The person is on telmisartan 40 mg. Do you agree with that? Remember, it's correct. RAS blockade should be the first line drug, but the dose is wrong. Remember, for diabetic nephropathy, nephroprotection, you should go to 80 mg telmisartan. So the message is all ACE inhibitors or ARBs, whatever you are using, use full dose unless the patient has side effects, and do not combine ACE or ARB. Both should not be combined, any of them. So telmisartan dose was increased to 80 mg. Still, after that, the blood pressure was not controlled. So what should be the second line drug in diabetic nephropathy? Calcium channel blocker can be used. Then still not controlled, you can go for loop diuretics or thiazide diuretics depending on the GFR. Then mineralocorticoid receptor antagonists, then minoxidil and hydralazine. Lastly, clonidine or moxonidine. This is the way it should be used in a patient with diabetic kidney disease. So this patient was therefore initiated on telmisartan, made 80 mg, amlodipine was added, and chlorthalidone was already there. So triple drug combination. So that was about BP control. His BP got controlled. What about blood sugar? Target 6.5 to 8 is the latest guideline in diabetic nephropathy. Why the targets are so much varying? For younger patients who are not having any other comorbidities, who can manage hypoglycemia, you can go for stricter target. So for this patient, software 47 years, go for 6.5. For older individuals who are staying alone, hypoglycemia, unawareness, many comorbidities, go for lighter target. 8 is okay. Remember, HbA1c is not very accurate, but still we use it. It may be falsely low or falsely high in case of diabetic kidney disease. So use it with a pinch of salt. This is the best available as of now. But as you must have heard yesterday, continuous monitoring of blood glucose is also coming in a big way in diabetic nephropathy, where you have a discrepancy between the blood sugars and HbA1c. So this can also be used. So glycemic targets I've told you. Now, how do we attain these glycemic targets for diabetic nephropathy? Remember that it's not only glucose control now. Glucocentric approach is not enough. We should look at protection of other organs, preservation of beta cell function, weight reduction, minimum hypoglycemia. So all these things and a good quality of life. So what drugs is this patient on? He is taking metformin and glimepiride. Is that correct? His GFR is more than 30. It's around 36, which we saw. So this person, metformin continuing is correct. You can continue with the metformin. Depending on the GFR, you can adjust the dose. So more than 60, same dose. 45 to 60 also same dose, but you have to monitor carefully. 30 to 45, half the dose. And less than 30, stop metformin. So metformin still remains the first drug of choice for renoprotection as well. Now, second, what do we do? SGLT2 inhibitors. they have come in a big way, and they should be the second drug of choice. In this patient, they are not there. So you may say SGLT2, they reduce the hyperglycemia by excreting sugar in the urine. How they are renoprotective? They are renoprotective because they counteract the hyperfiltration. The kidney damage occurs by hyperfiltration. We know that as there is more and more nephron loss, the remaining kidney starts hyperfiltering. The more nephrons work, the more disease they become. So overwork spoils the kidney. Hyperfiltration spoils the kidney. And how do SGLT2 inhibitors help here? We all know that SGLT2 block the SGLT2 in the proximal tubule. And as a result, what happens? More sodium and glucose, it reaches the distal tubule. And in the distal tubule, what happens is we have macula densa, which receives this sodium. And then what does it do? It tells the efferent arteriole that already I'm receiving so much of sodium and glucose, so do not filter more blood. As a result, there is constriction of the efferent arteriole and there is decreased pressure inside the glomerulus. And this brings down the hyperfiltration. And this is the main mechanism of renoprotection by SGLT2 inhibitors. They have other mechanisms as well, but this is one of the main ones. And that is why they are very smart drugs. They are helpful in weight reduction, reduce the BP, cardioprotective, they reduce hyperfiltration, they are smart diuretics, they decrease the albuminuria, decrease the renal work, and decrease inflammation. So many mechanisms of action and multi-pronged effect of SGLT2. So this drug should be added in the prescription. Therefore, for this person, dapagliflozin was added 10 milligram, and chlorthalidone was reduced to avoid the risk of dehydration, because dapagliflozin also causes some renoprotection by excreting the extra water. So what happened was creatinine went up to 2.2 and the urine sugar became 3+. So patient was scared that creatinine is going up, but we told that that can occur with dapagliflozin, no need to stop it. Future renoprotection is going to be there. So the albumin had come down, but not totally come down after dapagliflozin. Creatinine started declining. So after DAPA and metformin, what do? SGLT2 is not enough. You have residual risk after SGLT2 as well. So what is the next step? Next step is to add GLP-1 receptor agonists. So these are other renoprotective drugs which should be added if the patient is not well controlled on SGLT2, or if the patient does not tolerate SGLT2, these can be added. So these are other important renoprotective drugs. So this was done. The patient was started on liraglutide as well. Now, is the prescription complete? Do we need to do anything? Still some proteinuria is there. Around UPCR is the protein is around 430 milligram, not normal. So the creatinine has come down. So now we have evidence from Fidelio trial and you have Fidelity trial which show that finrenone can be added. It is renoprotective and cardioprotective. So this is another new drug for the management of diabetic nephropathy, which helps in renoprotection. So 10 milligram finrenone was added. So now the prescription looks like this. Is this complete as of now? Let us see. Any other therapy? Yes. Do not forget to add statin for all patients of diabetic nephropathy, even if the cholesterol is normal. This is for cardiovascular benefit. So above the age of 18 years, all diabetics with nephropathy should be on statin. Bicarbonate should be added to maintain serum bicarbonate 22. Aspirin is added only if the history of cardiovascular disease is there. Uricosuric agents, the uric acid was 7.4 for this patient, not required. Only symptomatic hyperuricemia you should add. Otherwise, many prescriptions we keep on adding allopurinol, febuxostat. Add if the uric acid is above 9 or if the patient is symptomatic. And manage anemia and mineral bone disease by giving iron and erythropoietin. This patient was okay. So diabetic nephropathy does not only mean glucose control. So many other parameters need to be looked at. So now this prescription seems complete. We have added atorvastatin, sodium bicarbonate was added as well. So recent concept is not glucocentric approach, it's a holistic approach. So coming to the end of my talk, the prescription which had 3 drugs written on it was not complete. And now the prescription is complete where you can see how many measures, 10 measures. So the 10 commandments for diabetic nephropathy. You may think why madam is talking again and again. This we all know, but this is a study published in leading journal. We are also authors of this in leading institutes from India. Only 40%, 48% patients are on RAS blockade, 40% are on statins, metformin only 25%, and iron and ESA therapy for diabetic nephropathy non-existent. So remember, it's important. There are a couple of recent advances. We have non-albuminic DKD, which we will discuss during the question hour. Where albuminuria is not there, still the patient has DKD. This is associated with more of macrovascular disease, and absence of retinopathy has a better prognosis. However, the drugs are not very effective. And we have so many other players as well. I'm not talking about that. This looks like a scary slide, but at the same time, an exciting slide, because so many pathways are there and new drugs are coming up. So, ladies and gentlemen, concluding, I have great regard for Indian doctors. We are all trying to do our best in our fields, but we are working alone. We need to collaborate. Together, we can make a difference. That's why the purpose of this seminar, the physician talking to the nephro and endos. Prevention is better than cure. You can see testing is only testing and treatment prevention 3,000 per month. Dialysis transplant is 30,000 per month. So I think this should be the main message. If you want to really take hold of diabetic nephropathy, screen them early, and for treatment, use a 10-point agenda. So this will go a long way in preventing diabetic nephropathy. Thank you for a patient hearing.